So if you have a focal density, you decide whether it's trabecular or has cortical organization. If it is trabeculated and has cortex, and I'll show you images of this, it's ossification. If it's if it doesn't have trabeculation or cortex and it's sort of diffuse and cloud-like, then it's calcification. The locations of these ossifications and calcifications are important to know. Ossifications occur when there is an avulsion fracture and the fragment itself is the ossification. As an accessory ossicle or a sesamoid bone, and as an enthesophyte. These are usually secondary to calcific tendinitis, hydroxyapatite deposition disease. When pathology occurs in the joints, ossifications form syndesmophytes, bony ankylosis, and intra-articular loose bodies. And calcifications in the joints most often are calcium pyrophosphate dihydrate crystal deposition disease. Other soft tissues, you can have myositis ossificans and heterotopic ossification. And if you are seeing calcification, then you're going to have idiopathic and secondary tumoral calcinosis, vascular calcifications and lesions, soft tissue tumors, and possibly infection. Step one, we look at the density of the calcification. Calcifications normally appear as mineralized density with an attenuation coefficient higher than soft tissue, but lower than bone. You see the ovoid calcification on the upper radiograph with the arrow head on it. This is a calcification because it's homogeneous and it's clearly visualized. It's located in the subacromial subdeltoid bursa. Step one, the density of the calcification. Using computed tomography, there is a wide range of Hounsfield unit values for calcification, which fall mostly between 100 and 400 Hounsfield units, whereas bone reaches much higher values, 700 for trabecular bone and over 1,500 for cortical bone. And looking at this transverse CT image of the shoulder, you can see a large calcification here posterior to the joint. Foreign body density varies depending on the nature of the material, but glass and silicone, among others, may have similar Hounsfield units to calcifications. You can see that there's a quadrilateral calcification here, indicated by the arrowhead. CT is more sensitive than radiography for almost everything and provides additional information regarding adjacent tissues, such as the location of neurovascular bundles, muscles, tendons, and inflammatory reactions. MRI shows various signal intensities on conventional spin echo T1 or T2 graded images, which can frequently overlook calcifications. Hence, the importance to correlate MRI with conventional radiographs on every occasion. Ultrasound is known to be more sensitive than radiography, however, when acoustic shadowing is present. It will prevent one from doing a complete assessment and being able to differentiate between ossification and calcification. So basically, the takeaway message here is that CT is better than radiography, but radiography is better than MRI and ultrasound when looking at osseous structures. The classic hydroxyapatite calcification has an amorphous and cloud-like appearance, as we see in the upper radiograph, with a well-defined oval contour. It can appear multiloculated and even show fluid levels. Linear calcifications are usually related to calcium pyrophosphate dihydrate crystal deposition. The image in B is an image of not calcium pyrophosphate disease, but hydroxyapatite deposition disease when it goes into its desorption stage and starts to disappear. In the upper radiograph, this nodular stage usually is not painful, but this kind of calcification, this serpiginous calcification, tends to be painful. So now we're going to go and talk about shape and pattern. Punctate calcifications, as indicated in the proximal tibia with arcs and rings, will be seen in cartilaginous forming tumors and are referred to as cartilaginous matrix mineralization. Radiographs of ossifications will show bony organization, as we see here, with distinctive cortical and trabecular bone pattern. Fatty bone marrow within the trabecular spaces can be identified on CT and on MRI, narrowing greatly the differential diagnosis. Immature ossifications are not so well organized and may be more difficult to diagnose. Foreign bodies will often show a distinctive shape, such as sharp and or geometric borders, helping identify their nature. Step 2, location. Once a calcification is recognized on a radiograph, its location can be determined easily when its shape follows that of the anatomical structure involved, or by more routinely using multiple oblique views around joints. CT also can be helpful, but it is most often not necessary. Here is a table that discusses the differential diagnosis of calcifications and ossifications according to their location. On the left in location, they can occur in tendons, in articulations, or in other soft tissues. When you have calcifications in a tendon, it is most likely hydroxyapatite deposition disease. Secondarily, you can have CPPD deposition disease, but this is rarer. If you have ossification in a tendon, this is most commonly an enthesophyte, an accessory bone or sesamoid, the sequela of a tendon rupture, and heterotopic ossification. Now I went into articular, sorry, I jumped, my fault. Articular calcifications are most likely calcium pyrophosphate dihydrate deposition disease. This is a disease that mimics osteoarthrosis, and we all should know about it. I will do a lecture later on about this entity. So you can have debris also from destructive arthropathy, as seen in Charcot joints, or you can also have hydroxyapatite deposition disease, but it's much rarer. Synovial chondromatosis, cortical injection may cause calcification. Gout with tophus formation may cause calcification. If you see ossification in the articulations, this is ankylosis, like as seen in ankylosing spondylitis or in the ankylosis seen in the late stage of rheumatoid arthritis. Syndesmophytes also may be seen, as seen in ankylosing spondylitis. Heterotopic ossification can be seen in the spine as lumpy, bumpy mounds of bone, secondary to underlying diffuse idiopathic skeletal hyperostosis, possibly surgery, or secondary to a neuropathic disorder. In other soft tissues, you can see idiopathic tumoral calcinosis as a calcification, secondary calcification, soft tissue tumors, including calcification within lipoma, chondroma, nerve sheath tumors, synovial sarcoma, and other extraosseous sarcomas. Vascular calcifications are common in atherosclerosis in the form of phleboliths in the veins, infection, and lymph nodes. The most frequent etiology are in bold. CPPD is seen as calcium pyrophosphate dihydrate, chronic renal failure, DISH, HAD, and myositis ossificans circumscripta. So now that we've done that, we go on to step 2, tendon calcifications. Calcific tendinopathy is usually made up of hydroxyapatite deposition disease, referred to as HADD. It's very frequent, and it is seen in 3 to 15% of the general population. It peaks in the 5th decade and can be bilateral in up to 50% of the patients. It is symptomatic in 10 to 50% of cases. It demonstrates multiple stages, having been described in the literature, which may help in our understanding the various imaging appearances of calcific tendinopathy. Unsoft's classification separates it into precalcific, calcific, and post-calcific stages. The calcific stage is further divided into formative, resting, and resorptive phases. Calcific tendinopathy, hydroxyapatite deposition disease, is seen on this radiograph. The formative and resting phases are associated with a dense, homogeneous, and well-defined calcium deposit. Clinically, these calcifications may be asymptomatic or present with a mild to moderate degree of discomfort caused by impingement of the bulky calcification on existing anatomical structures. The resorptive phase is characterized clinically by acute, sometimes excruciating pain